Rahim. As Professor Ashraf has indicated, can you see my slides on the screen, guys?
Yes, very nice.
Okay. I'm going to speak about the use and abuse of low molecular weight heparin. You see, in life generally, if anything is good, people will tend to overdo it. Anything, even religion, when it is good, people, they become very excessive and extreme in it. So it's very important to have a balanced approach to everything. And this is what we're going to discuss today. We're speaking about IVF, so it's important to speak at the beginning. And this was the beginning. This was the 25th of July, 1978, when Louise Brown was born in Oldham near Manchester in England. And she was cradled by Bob Edward, Patrick Steptoe, and Jean Purdy, the embryologist. And we all know that Louise Brown was a result of a non-stimulated cycle, a natural cycle. But now IVF in this day and age is almost always stimulated cycle. And we know with ovarian stimulation, there is increased level of hormones, definitely. There is probably hypercoagulability and possibly increased thromboembolism. And we know from studies in the non-IVF community that women in their reproductive years have an incidence of deep venous thrombosis of 5 in 100,000. If you give them the combined oral contraceptive pill, it increased to about 15 to 30 per 100,000. But if the woman is pregnant, with the excessive increase in the level of the hormones, you get about 70 per 100,000. And this is information to us to remind us that definitely increased level of hormone will increase coagulability and thromboembolism. And with IVF, surprisingly, it's not the ovarian stimulation that leads to the increased level of coagulability, but actually when you give the trigger HCG injection, then at that stage you have increased level of clotting factors. It's observed mainly within 2 days of the HCG and reaches a maximum about 8 days post HCG. So the question that comes here is, should we use low molecular weight heparin and IVF? Should we use it with everyone? Should we use it in specific circumstances? And more importantly, when we answer this question, is there any evidence for that? And as a funny story sideline, the reason why I thought of this lecture many years ago is the head of the pharmacy in my hospital. It's the biggest private hospital in Jordan with about 400 beds. Came to me and saying, what's going on? And I say, what's happening? I said, in the department of obs and gynae, you are prescribing more low molecular weight heparin that they are prescribing in the vascular department. So what's going on? And as we all know, our friends in obs and gynae have a tendency to use anything that ends up with IN. They like aspirin, they like heparin. You just put IN to the end of the drug name and everyone will prescribe it, whether it's indicated or not. So let's see if it's indicated or not. So we're going to cover 3 main points. Does IVF increase thromboembolism? Should we use low molecular weight heparin in IVF with thrombophilia patients? And should we use it in everyone else with IVF? So let's start with the first one. Definitely the incidence of thromboembolism is increased in IVF. We said it's 5 in 100,000 in the non-IVF, non-pregnant women. With IVF, you're speaking to 1 to 2 per 1,000 cycle. It has a propensity for the upper limb and neck. It could be arterial or venous. The incidence of arterial is mainly 10 days post-embryo transfer if she gets pregnant, and the venous later on. This is a graph showing us how IVF increases the level of DVT. It is similar to pregnant women. The incidence of DVT in pregnancy is about 70 per 100,000. With IVF, it's 100 per 100,000. You wouldn't use low molecular weight heparin in pregnant women with no risk factors, and the same with IVF. But if the patient develops ovarian hyperstimulation, it's significantly increased, 5,000 per 100,000, 5%. This is what we say. So definitely we should use it there. Sorry. Okay, so if the patient gets pregnant after IVF, the incidence of DVT in the first trimester is increased by 10-fold, about 170 per 100,000 compared to 16. But if she gets pregnant after ovarian hyperstimulation syndrome, that it's increased about 100-fold. So not only ovarian hyperstimulation syndrome increases the level of DVT, also ovarian hyperstimulation syndrome followed by pregnancy. Therefore, the recommendations from the Royal College of Obstetrician Gynecologists is low molecular weight must be used in IVF patients with severe ovarian hyperstimulation syndrome. And if you're wondering which ones are the ovarian hyperstimulation syndrome, then I would recommend the ones that you admit to hospital. Anyone who is admitted to hospital with ovarian hyperstimulation syndrome will require to have low molecular weight heparin. And I love it that sometimes the clinician would admit a patient and try to aspirate the ascites, and then they tell us this is mild to moderate. No, it's severe. Also, if the patient with OHSS gets pregnant, then you must give her the low molecular weight heparin all through the first trimester, even if the OHSS subsides earlier on in pregnancy. And that's very, very important because we saw there is like 100-fold increase in the level of ovarian hyperstimulation syndrome and DVT. The question that begs itself, if we give any drug early in pregnancy, is does it increase the level of miscarriage? And we have a Cochrane review to look at if heparin for assisted reproduction increase the level of miscarriage, and I'm happy to reassure you that there is no evidence on the level of miscarriage. It doesn't increase the chance of miscarriage. The other thing people ask about is, does it increase the level of subchorionic hematoma? You know, sometimes early in pregnancy, you see the pregnancy sac, you see the fetus, and there is a small bleed in the subchorionic space. And there is data from this observational study published in Fertility and Sterility in 2016 that looked at the effect of both heparin and aspirin on subchorionic hematoma, and heparin does not increase the incidence of subchorionic hematoma, but aspirin surprisingly does. And therefore, if you have a patient on low-dose aspirin for whatever reason and she develops subchorionic hematoma earlier in the first trimester, my recommendation is to stop it till things settle down. The next issue we want to discuss is the more meaty one, is what about patients with thrombophilia? Let's just review what is thrombophilia. Thrombophilia is the condition of increased chance of intravascular thrombosis. It could be congenital or acquired, and it often coexists in combinations. And there is wide variation in the incidence among population. Basically, clotting happens when we bleed externally, but our blood is kept fluid inside our vessels. Otherwise, we'll get a clot, jalta, as we say in Arabic. There is a balance between the clotting factors that cause the clotting and the anti-clotting factors, antithrombin 3, protein C, and protein S. And if there is any mutation in the clotting factor or any deficiency in the anti-clotting factors, then you get congenital thrombophilia. And the incidence in the Western population, and you have to remember here that most of us study from Western books. The number of Western books is proportionally more than the local books. So the incidence in the Western population is about 8%. But studies that have looked at the incidence of thrombophilias in our own countries find that they are much higher than the Western population. So if you look at factor V Leiden mutation, 5% in Europe, but in Jordan, in Syria, and Egypt, where it has been looked at, it's almost 15%, 3 times the incidence. So if you find a patient who has factor V Leiden mutation, no big deal. 15% of your patients, about 1 in 8, should have it even with no problem. Also, if you look at prothrombin gene variant, you'll find the incidence in Europe in just 10%. It's about 5% in Jordan. It has been studied in the University of Jordan. So our incidence is different. When should we suspect thrombophilia in an ART patient? Definitely family history of recurrent thrombosis at different ages is a factor. It is said that 60% of patients who have had previous DVT would have thrombophilia, and some studies suggested that severe OHSS is associated with thrombophilia, and some old studies also suggested that recurrent implantation failure patients, those are patients who have gone through 2 or 3 IVF cycles, replacing about 6 or more embryos with no pregnancy. This we call recurrent implantation failure, and they tend to have a higher incidence of thrombophilia. And this is a study we published, about 10 years ago in Reproductive Biomedicine Online. We looked at 273 cases of recurrent implantation failure, and we found that in about 31% of them, they have either congenital or acquired thrombophilia. That's compared to the 10 to 15% natural incidence in our population. So, low molecular weight heparin and recurrent implantation failure and thrombophilia. Logic dictates, and I emphasize its logic because studies have not been done properly to show it, that if you're going to give low molecular weight heparin during pregnancy, then its use during IVF should be seriously considered. So if you're one of those obstetricians whom, if they see a patient with previous DVT or previous with a history of thrombophilia, and you think in pregnancy it's indicated, in my opinion, to give her low molecular weight heparin, then definitely IVF should be an indication because you increase the level of hormones. So in recommendation, we would say low molecular weight heparin should be used in recurrent implantation failure patients with thrombophilia and should be considered in IVF patients with thrombophilia. Practically speaking, I use it, but I know that the evidence for it is weak. So if I see some of my colleagues, the clinicians, not using it, I think they are right. I teach my juniors that sometimes things in life are black and white. You must use something because it's wrong not to use it. And sometimes it's not black and white. If you want to use it, that's fine, but keep in your mind that I may not be doing the right thing. So if new information comes about, you will have your mind open and your eyes open to learn it. You know, learning doesn't involve just the arrival of new information. It involves us opening our mind and opening our eyes in order to accept this new information. And very important that all of us, at whatever level of juniority or seniority, that we have our learning stance like this. Okay, now some people say, if we're going to use it for thrombophilia and recurrent implantation failure, why don't we use it for unexplained recurrent implantation failure? What can go wrong? Not much can go wrong, but let's see if it has been tested or not. Yes, it definitely has been tested in a number of studies and a meta-analysis, and they found that if you use low molecular weight heparin in unexplained recurrent implantation failure, that's in patients who do not have thrombophilia, there will be no benefit whatsoever. You may feel better, your patient may feel that you've done your best, but when you get more pregnancies, no, you won't get. So there is no evidence for use of low molecular weight heparin in unexplained recurrent implantation failure. That's empirically. Okay, finally, should we use low molecular weight heparin in IVF in general? Now, the idea is appealing, I must admit. You start with 2 cells, a sperm and an egg, and you end up with a beautiful baby, billions of cells. So a lot of new blood vessels, a lot of growth factors are required here. And definitely in the lab, the heparin is recognized to be a major promoter of growth factor in the intrauterine environment, in the decidua, anywhere in the body. And that's why people have thought, why don't we use heparin for everyone in IVF? And a lot of our colleagues, as you and I know, do that. But studies have been done. There is a Cochrane library review. There is also a meta-analysis by our colleagues, Yaqub Khalaf and Tariq Touhi from St. Thomas's and Guy's, and Haytham Hamouda, and they have found that there is no benefit of using low molecular weight heparin in the general IVF population, either on live birth rate, either on implantation rate, or no benefit in reducing miscarriage rate. So the recommendation that there is no evidence for the use of low molecular weight heparin in the general IVF population. So, Mr. Chairman, my colleagues, I will conclude by saying that low molecular weight heparin must be used in IVF patients with severe ovarian hyperstimulation syndrome. And if they get pregnant, it must be continued through the first trimester. It should be considered in recurrent implantation failure patients with thrombophilia, and also in IVF patients who have thrombophilia. And as I said, if you're going to use it during pregnancy, then you use it during IVF. But there is no evidence for using it in low molecular weight and using it with unexplained recurrent implantation failure or in the general IVF population. Also, it's reassuring when you use it that it does not increase the rate of miscarriage nor the rate of subchorionic hematoma. Thank you very much for your attention.